We are live now.
Yes. Good evening and good morning to our fellows. So we come to the second session of our management of cerebral palsy. And in today's program, we are going to discuss some important points. Now, after the last meeting, we got a lot of questions from fellows and even for the teachers also. So I am really happy that we are actually interacting. We can interact during the program also and after program also. So I suggest you that if you have any question, any feedback, any suggestions for the improvement, please send me an email at ganjwala@gmail.com. So in the first session, we will start with the input from fellows. And in that, we had two important questions. The first was about the role of early diagnosis followed by early intervention. So we had a question, does early intervention, particularly the early treatment in the form of therapy, improve the outcome? That was our first question. And then if we have some evidence to suggest that yes, early intervention or early treatment is important, then the next question was, how does it work? So what is the mechanism by which it actually works? So with that, I will stop sharing now, and I will request Devendra to share his or his team's view on that.
So, good afternoon, sir, and I would like to present my. Good afternoon, sir. I would like to present the topic which was given to me: early intervention in cerebral palsy. I am Dr. Devendra. I am working as a senior resident in Department of Pediatric Orthopedics, KMC Manipur. So early and accurate diagnosis and early intervention in cerebral palsy. So majority of my talk will be centered on this article, which was by Novak et al. In 2017. It was published in the Journal of American Academy of Pediatrics, and it's a systematic review. And data was collected from Medline, Embrace, and Cochrane Library, and 6 systematic reviews and 2 evidence-based reviews and 2 evidence-based clinical guidelines met the inclusion criteria. So their findings were that before the paper consists of 2 parts. First is early diagnosis, then early intervention. So in early diagnosis, they say that the cerebral palsy can be diagnosed before even the 1 year of life, and clinical signs emerge and evolve before 2 years, and before 5 months, corrected age, MRI, and qualitative assessment of general movements, and the Hammersmith infant neurological examination. These 3 combined can give 95% with 95% accuracy the diagnosis of CP. After 5 months of age, MRI and Hammersmith scoring can give up to 90% accuracy. It can give the diagnosis of cerebral palsy. So when there is in resource poor settings where MRI is not available, Hein can be the Hammersmith score can be used alone. And so Hein scoring is a simple scoreable standardized clinical examination for infants between 2 and 24 months of age, and it predicts the likelihood of CP and probable motor and severity of CP. And the score of 50 to 73 indicates a unilateral CP, and less than 50 indicates bilateral involvement. There are 3 parts to the score: neurological examination, developmental milestones, and behavior. So neurological examination includes 5 domains: cranial nerve function, posture, quality and quantity of movements, muscle tone, reflexes and reactions. Total score is 78, and each of this variable is scored from 0 to 3. So regarding intervention, sir, hemiplegic cerebral palsy who receive early constraint-induced movement therapy have better hand function than in short term, and probably substantially better function in long term. So what is constraint-induced movement therapy? It is based on Dr. Edward work of Dr. Edward Taub, and it is based on the principle of reversing learned non-use. So constraint-induced movement therapy is a form of rehabilitation that improves upper extremity function by increasing the use of the affected upper limb. So in this, the children, the non-affected limb is put in a mitten or a cast or any other uh, splint, so that the child does not use it, and the child is encouraged to use the affected limb in hemiplegic individuals, and forcing the use of upper limb with the goal of promoting purposeful movements and when performing functional tasks. CIMT involves supervised structured task with affected limbs 6 to 10 hours a day for 10 days over a 14-day period, in addition to wearing the restrictive mitten or the restrictive device for 90% of the waking hours. So infants with hemiplegic CP who receive CIMT have functional gains in the short term, and at 8 years of study, after 8 years of study, in the long term, that I mean, the results are equivocal, and more research is required in this modality of treatment. So, and the other one is goals, activity, motor, and enrichment. So this involves activities in at home, and in this intervention, whatever is the deficiency, it is individualized to the CP patient, and whatever is deficient, a program is designed, a play-based program is designed, in which the child is encouraged and encouraged to develop the skill, and targeted activities are designed as per the whatever is the deficiency in the child. So the intervention is offered via home visit fortnightly until first birthday. So this intervention resulted in advanced motor and cognitive outcomes when compared to standard care in the short term. So their recommendations to prevent secondary impairment and minimize complications. In that paper, as far as orthopedic intervention is concerned, they had advised that every 6 to 12 monthly radiographs are required to for hip surveillance to detect early signs of dislocation, and for neurologic anti-epileptic and pharmacological intervention was suggested, and for urinary tract bladder for the bladder, medical investigation should be conducted to find anatomical abnormalities and treat them early, and longer toilet training has to be given to the CP children. So sleep, for better sleep, like sleep hygiene, which meaning that proper sleeping time hours, and avoiding of screen during just before sleep, and parental education, and melatonin or gabapentin to enhance sleep in those children specifically where it is a problem, and for sialorrhea or excessive salivation, botulinum toxin and benzatropine is useful. And for ophthalmological early screening and ophthalmological intervention is required. So I conclude by saying that brain development and refinement of motor system continues postnatally, and cerebral palsy specific early intervention maximizes the neuroplasticity and minimizes the deleterious modifications to muscle and bone during growth and development. Early active movement and intervention are essential because infants who do not actively use their motor cortex risk of losing cortical connections and dedicated function. There is increased evidence that infant motor behavior via discovery, interaction with the environment controls and generates the growth and development of muscle, ligament, bone, and it helps in ongoing development of the neuromotor system. So there are some ongoing studies which are happening. That is CIMT with versus bimanual, means using of both hands, and the goals activity versus usual care, and even the use of erythropoietin in case of neonatal hypoxic encephalopathy, and erythropoietin plus hypothermia or hypothermia alone, and even cord blood versus hypothermia and hypothermia alone. So all these are undergoing, and the findings are yet to be out regarding for this.
Yeah, thank you, Devendra, for a very good summary of the literature. But again, I just would like to ask you that early intervention, by that we mean that we make or we suspect a diagnosis at the age of 2 months or 3 months, and then we start physiotherapy. That is what I understand by early intervention. And the question is, how much is the evidence we have for such early intervention? So I will ask first Benjamin and then Freeman. Benjamin, if you have a patient who is suspected of having a possibility of cerebral palsy at the age of 3 months, will you start early intervention in the form of physiotherapy to that child, or you will wait till the child is 7 or 8 months or even 1 year or so? You need to unmute yourself, sir.
Yeah, sorry. Yeah, I wouldn't mind introducing them to the concept of starting some physiotherapy so that they know that this is what they're in for and that it needs to be a prolonged affair. But I was listening to the review which they were given and which is very good. But the bottom line is, at 8 years, the difference between those who had intervention and those who didn't was the difference of equivocal. So one wonders, there is no strong evidence that there's a long-term benefit. There certainly seems to be a short-term benefit. Some of the skills that are acquired a little earlier, and to that extent it is useful. You see, one of the things that is sad is that sometimes we have encountered children who have cerebral palsy, and once the parents realize that the child has got a problem, they neglect the child completely without any stimulation. So that has profoundly adverse effects. That shouldn't happen. But on the contrary, to be too concerned that we don't have a setup of physiotherapy and occupational therapy in the community to give early intervention shouldn't be a source of very great worry, because if we can at least prevent complications in the form of contractures, teach the parents stretching at least, if not anything else. You'd also notice that the upper limb was mainly what was talked about in terms of putting a cast and restraining the unaffected limb, because it's not relevant in the lower limb. So it has got limited use. There are children who neglect the use of the upper limb completely. Those may benefit from it, at least for the short term. But yes, there are interventions, but let's always remember that some of the acquisition of skills or motor milestones may occur independent of intervention because of the postnatal myelination of the neurological system. Yeah, so if your question as to whether I would intervene, I don't mind introducing them to the concept of long-term physiotherapy, which they'll need till the child completes growing. So to that effect, I don't mind doing it, but I wouldn't push hard and say every child in 3 months or 4 months should start with energetic intervention schemes.
Okay, thank you. So that was one of the questions, because in my city, if the diagnosis is made at 2 months or 3 months, we recommend, we means like almost every practitioner recommend the child to go to a center almost 5 days in a week and carry out some sort of treatment. So there are two things. The one is the family has to spare a time, and we have a limited time of 24 hours, and whatever we spare or spend after one particular child is actually at the cost of other child or the other family members. And again, the second problem is about the cost, because going for therapy and spending for the therapy, these are the another issues. So I am really like keen to listen to Freeman's view on that. Like, what is the status of early intervention in USA?
So in the U.S., most children who are felt to be at risk or have any early diagnosis will be referred for early intervention. And frankly, that early intervention, from my perspective, that's most important, is supportive to the parents, supportive to the mother or the primary caregiver. And I completely agree with the concept that you have to be careful not to overload the parents so that other children may be neglected. The other part of it is, a part of what I think early intervention really is beneficial for, though, is to help parents to manage a child who isn't following normal developmental guidelines. And they may be getting frustrated and then sort of give up and, as was mentioned, sort of start ignoring the child. And I think that's the early intervention is most beneficial for that. And I am less convinced that specific techniques are that much more useful. And there's a lot, as was mentioned in the excellent overview, there are studies ongoing comparing constraint use therapy with bimanual therapy. And in the end, there really, as far as I know, is no evidence at this point that either one makes a long-term benefit, meaning that the child is different at age 14 if they had it as a parent as opposed to not having. But I think on the other hand, it also does not harm. And sometimes you see very dramatic results in the short term. And but the carryover is difficult. And it's these are the problems. I do think early intervention is used widely. It's generally has large variations in this country about how it's applied. But I do, and my personal opinion is that its greatest benefit is to help the parents. And especially if you have a situation where a grandparent is supporting, which often is the case, a mother in the care of early, if they're first or second child, the grandmothers often have no experience either with this kind of child. So you're really, that is really where the benefit of early intervention comes in, from my estimation.
Okay, so basically still we are not having a evidence-based support to for the early intervention. But yes, what you said is like to make them, like counsel them or to support them. Early intervention definitely plays a very important role. There was another very good review which Devendra did not include, that was in Developmental Medicine Child Neurology. Again, the article says that yes, we have a very small evidence to support early intervention. So still we are not clear about exactly how it is helping, how much it is helping. So probably the future literature will definitely help us. So now we go to the second exercise. And the second homework, which we gave, and I request Dr. Akash Ghosh to present his views. So that was about the Prime Minister of India wants to eradicate cerebral palsy, and Akash and his team is going to give recommendation to Prime Minister what needs to be done. Akash, you have two strong person, Benjamin and Freeman. They are even like more vigilant than our Prime Minister. So be careful.
Yeah. Yeah, so good afternoon, everyone. I'll be talking about the etiology and possible preventive measures for cerebral palsy. This presentation has been worked upon by me and Dr. JP Khatri. We are pursuing MCH Pediatric Orthopedics at PGI Chandigarh. So most of the etiologies presented here, I have consulted Dr. Freeman's book on this. Just a minute. Yeah. So the etiology of cerebral palsy, it can be broadly divided into congenital or antenatal causes, neonatal, perinatal causes, and postnatal causes. So before presenting anything, I would like to say that there is no 100% short method of preventing cerebral palsy. We can reduce the risk of having cerebral palsy, but we cannot completely prevent it. So the congenital and antenatal causes, these are the bulk of the causes which this constitutes the bulk of etiology of cerebral palsy. These are mostly consist of disorders of brain development, like encephalocele, which is a neural tube defect, less common than meningomyelocele, which is the distal defect. This is a proximal defect. Schizencephaly is absence of one part of the cortex, like this picture here. This is schizencephaly. Then microcephaly or megaloencephaly, which can be like microencephaly. It can be due to various infections like the torch infections. Then lysencephaly is absence of gyri. And other defects are focal cortical dysplasia and disorders of synaptic formation and remodeling. These disorders of brain development, they usually have a genetic component which may or may not be diagnosable. So yeah, the risk factor. So the defects in the disorders of brain development, these were the causes, the antenatal causes of cerebral palsy. The risk factors which predispose to these defects are antenatal infections like maternal torch infections, which constitutes of toxoplasmosis, rubella, cytomegalovirus, herpes, and syphilis. Then even maternal drug and alcohol consumption has been shown to contribute to disorders of brain development. RH incompatibility, this has been a major advancement in prevention of cerebral palsy, because now we have started screening for RH incompatibility. RH incompatibility later results in erythroblastosis fetalis and Kernick-Terrace, which can also contribute to athetoid type of cerebral palsy. Then prenatal chorioamnionitis and preeclampsia have been shown to contribute to the risk. So most of the antenatal causes lead to like disorders of brain development. They lead to quadriplegic involvement. So preventive measures for antenatal checkups are antenatal preventive measures are regular antenatal checkups and proper immunization, RH incompatibility screening, and like for neural tube defects, maternal folate and iodine supplementations. Then as maternal alcohol and drug intake has been shown to be a cause, so avoiding alcohol, cigarettes, recreational drugs. Then screening for asymptomatic bacteriuria, as bacteriuria is a risk factor for chorioamnionitis. And antiplatelet drugs to prevent preeclampsia. These are some of the antenatal preventive measures that can be adopted. Then perinatal causes. So this is one interesting fact I came across while reading up about this, that fewer than 10% of injuries that result in cerebral palsy occur during the birth process. So this when we counsel patients, it's mostly most of it comes down to the, like we explain it with perinatal hypoxia, but fewer than 10% of injuries occur during the birth process. And the cause is either intraventricular hemorrhage or hemorrhage around the ventricles, which is called germinal matrix hemorrhage. And if there is cystic changes due to these hemorrhage, it's called cystic periventricular leukomalacia. Hypoxic ischemic encephalopathy due to perinatal hypoxia, which can again, if it causes cystic changes, it is called multicystic encephalomalacia. And neonatal stroke is another cause, which cystic changes in neonatal stroke cause porencephaly. So whenever there are cystic changes, the condition is more severe and the prognosis is poorer. So there is a grading of intraventricular hemorrhage based on the ultrasound examination, and with increasing grade, the severity of the cerebral palsy increases. So grade 1 is confined to the periventricular germinal matrix, and grade 2 is bleeding into the ventricle without dilation, and in grade 3 there is bleeding into the ventricle that causes dilation, and grade 4 is the most severe, in which bleeding extends into the brain parenchyma. So perinatal risk factors which increase the risk for the causes I discussed before are low birth weight and preterm deliveries. These are the most common. This is due to in preterm deliveries, there's preterm babies, there's the blood vessels are fragile and more prone for intraventricular hemorrhage. And neonatal sepsis is also a cause of neonatal stroke. Prolonged mechanical ventilation, fetal distress, prolonged labor, cord prolapse, breech presentation, and multiple gestation. These are the perinatal risk factors. So how can we reduce these risk factors? So one is trained delivery personnel with neonatologist support, and stringent fetal non-stress test monitoring. We usually nowadays we do a topograph and we monitor the fetal heart rate. So it is very essential to monitor for late decelerations and to watch for fetal distress, and appropriate vaccination and screening for neonatal jaundice. Other preventive measures are in cases where there is impending, we are expecting a preterm delivery, we can try to prolong the pregnancy a bit by giving oxytocin antagonists like atosiban, and calcium channel blockers, and antibiotic erythromycin in premature rupture of membranes. Also, the administration of before delivery, the administration of glucocorticoids and magnesium sulfate has been shown to be neuroprotective. And therapeutic hypothermia after delivery, there is still a debate on whether we should give a full system hypothermia or just to the head. And administration of glucocorticoids after delivery has been shown to be detrimental, and it also to increase the risk of cerebral palsy. Then postnatal causes. So postnatal causes, it's mostly due to postnatal trauma, which can be due to child abuse, motor vehicle accident, falls, metabolic encephalopathies, infections and meningitis, like meningitis. Then toxins and anoxic events like drowning or hanging. So postnatal preventive measures include timely immunization, and steps should be taken to prevent the injuries from occurring, like baby proofing the home and play areas, and car safety, and like to install a car seat and with safety belts. And the child should never be left unattended. So thank you. Yeah.
Thank you, Akash, for very beautiful description of the preventive measures. And from that, we can understand that still we are far from our goal of reducing or eradicating the cerebral palsy, because a lot of things which we don't know, and that we are going to discuss in the today's discussion. So let's continue with the same one. I hope you are able to see the slide, right?
Yeah.
Yes.
Yeah. Okay, so one point which I wanted and what you describe is that whenever there is a predisposing factor, like say asphyxia or hypoxia, there is a mechanism by which the disease is produced. So I have thought of this concept along, but recently I read about it, and I think that it's very important us to or understand. We saw in recent COVID epidemic that there are a lot of patients who got COVID infection. Very few of them got the pneumonia, and they required support or hospitalization. But on the other end, we also know that 20% or 30% of the people, they have no problem at all. It was just a very mild episode of fever or the sore throat, and they recovered uneventfully. So now the question is like, why some went on the downhill and why some people they want on the or without any problem. So almost the same thing happens in the cerebral palsy. That's a hypothesis that there is an insult to the brain in the form of hypoglycemia, in the form of hypoxia, in the form of a reduced blood pressure, which leads to cerebral palsy in few of the children. But there are few children who pass unaffected even with this insult. So we really need to understand that what are the preventive things in the body which is not causing cerebral palsy in every child who had brain insult. And what I am expecting in the near 1 or 2 decade is we understand the pathophysiology, why this is happening, what is happening in the tissue level, and if we can stop these mechanisms by somehow by some medication, like by hypothermia, by giving a steroid, then probably we can reduce the incidence of cerebral palsy. That is what my understanding about this. Freeman, what would you like to say about this? Is it possible in near future, or how far we have reached to this preventive aspect?
Yeah. Well, I think there has been a fair bit of progress, and I think that was an excellent overview, sort of, of where things are going. I think the problem with eradicating cerebral palsy is its multiple parameters, multiple etiologies. And there is some data that's suggesting from Australia and from Europe that the incidence of cerebral palsy in those countries may finally be coming down. And it's coming, and the hypothesis currently that it's coming down slightly due to 3 things. One is better early imaging of early in pregnancy, identifying these brain malformations early, and then the pregnancy gets terminated. So that has an impact. Also, there's a lot of assisted fertility, and in the past, they were often putting 2 or 3 pregnancies trying to, yes, ovum. And now they say that they are really going to doing just 1 because of the risk of cerebral palsy is higher with multiples. And then clearly the benefit of the treatments, hypothermia, is probably making some difference in a certain subgroup. And the third part that has been pulling back and not trying to save smaller and more fragile babies, sort of recognizing when the risk of severe disability is just not feasible, so that you terminate care when there's no reasonable chance of developing a good outcome. So those 3 things, I think, are all sort of approaches to decrease the incidence. And I think, other things like identifying patients who are at risk for hypercoagulable states, maybe having them be anticoagulated to avoid some of the in utero strokes, that occur and cause hemiplegia. And certainly, as we'll talk later about some of the early diagnosis of some of the metabolic conditions, so that we can actually avoid cerebral palsy.
Good. So with that, let's move further. And I just would like to say that if you go to a gym and if you carry out the strengthening exercise or the weightlifting exercise, then only your muscles are built up. So my request to all the fellows that when it comes to taking a homework, unless and until you actually carry out homework, you are not going to get any benefit from active learning. So by just going to the gym, watching the person doing exercise is not going to help us. We have to carry out exercise. So whenever we ask you to take part in the active learning, please take the homework and come prepared so that everyone is benefited. But the most important thing is like you will be benefited by preparing it. I read about this, why cerebral palsy is so common in one book. Again, it's a hypothesis. There is no scientific proof. But that says that mankind, particularly our species, has no great power compared to animals. We don't have speed, we don't have claws, we don't have power, we don't have fangs, we don't have fins, but still we rule the animal kingdom. And our supremacy is because of two reasons, mainly to the intelligence, and the second, our ability to work as a team. Now, for good cognition, good intelligence, we need a larger brain. And it's not possible for nature to allow that large brain to come out of female pelvis. So what nature does is like they kept only 1/3 or 1/4 of the brain prepared at the time of birth. And most of the neural development takes place after the birth. And that is why when the child is affected by some or the other reason at the time of birth, that results into a problem in that remaining development. The 75% of the development which is going to take later after the birth does not take place or is slow to take place, and that results into cerebral palsy. Now we come to a very simple question, and in this question I want every fellow to participate because this is a very simple question. The question is like what difficulties these children have. So I want you to come out with the answer, like what you have observed when they come to you. They say that these are the problems. So what are the problems which you have observed? Yeah, please. Unmute yourself and start enumerating the difficulties which these children have. Okay, someone is right.
Mobilize and move around.
Okay, so difficulty or difficulty in the movement, right? Difficulty in walking. Good. So that's one thing. Then there is motor difficulty. Akash has also written the same thing. Yes. So they have a motor difficulty, which makes them difficulty to turn around, to sit, to stand, to walk without support, run. So all these are the problems. Anything else?
Speech and hearing.
Speech and hearing. Okay, so what is a problem in the speech and what is a problem in hearing? Yes, anybody would like to say something? The point which I want to emphasize is that it's not only a motor disease. There are a lot of other things in these children. Ocular. Okay, ocular problems, right? Or vision problem. Good. What else?
Cochlear issues here.
Okay, cochlear issues, right?
Learning disabilities.
Learning disabilities, very good. Why there is learning disability?
Difficulty in social interactions.
Difficulty in social interaction, right? Good. So the point which I would like to say here is that a lot of children I would say almost all children have a known motor problems by one or two of the problems which I'm going to enumerate. The first is a lot of children have a vision problem. It may be a squint, it may be retinopathy of prematurity, it may be a problem with the central vision, it may be a high myopia. So all these affect a vision, and vision is very important for maintaining the balance and walking. So when vision is affected, definitely children have a lot of motor problem. The another issue is convulsion. They have a seizures disorder, and because of that, every time they have a seizures, there is some additional brain insult is taking place. The third is a lot of children have a problem with the intelligence. I was reading one review and that says almost 50% of the children having cerebral palsy have a problem of intelligence. The fourth one is a problem of speech or a communication. The speech may be affected primarily because of the speech area involvement, or it may be secondary to hearing problem. Because when the child is not hearing properly, definitely that would affect the speech. And in addition to that, there are same problem with the oromotor muscles, the muscles which allows the swallowing or the chewing. When that is affected, there is a feeding issue. So basically now the question is, if we want to treat cerebral palsy in a best way, then we need a multidisciplinary team. So I will ask Dr. Benjamin, like, how would you, or what will be the ideal multidisciplinary team according to your understanding?
Well, when you say ideal, it becomes a little worrisome because the ideal is often
Possible.
Yeah, well, the minimum I would say is that you need a good occupational therapist, you need a good physiotherapist, you need a good pediatrician who can understand what you're trying to tell them, and you need a good neurologist, apart from an orthopedic surgeon. Now, one of these people must take the lead so that the treatment of the child is not disjointed and in little bits. So if someone can run a comprehensive cerebral palsy clinic, there's tremendous advantages, tremendous advantages. A lot of the counseling that we plan to do, you don't need to do it because the parents talk to each other and tell each other, this is what we do, this is what has helped us. And so it primes them when they come. So this is the minimum that you do need. Now you can have special educators, you can have a lot of other personnel involved, but I think this is the basic that you can do, and I think you can put together a team very easily in any institution, which has got basically these personnel. The only thing I would say is someone has got to take the lead, and there shouldn't be a clash of egos. If the neurologist wants to run it, that's fine. Join them. Don't run two parallel clinics because it'll be very confusing for them. You'll have a pediatric physiotherapist and you'll have an orthopedic physiotherapist saying two different things, and the poor parents are confused. So to have accountability, I think you need it under one head and make sure that everybody gets to see the child. We succeeded in setting up a clinic in cerebral palsy in 1985, and it's still running. And we have a dedicated team working with us. So I'm immensely grateful to the physiotherapists and occupational therapists who worked with us. And, you know, we had the support of the neurologists and pediatricians and so on. Occasionally, you have to go further. You need to have a pediatric gastroenterologist when there are feeding issues. You might have to have, you know, they might have constipation, which can be quite distressing. So you need some of them. Then you can end up with scoliosis. You need a spinal surgeon involved. So you do need more people, but I think we start with the basic and start off with a team that can deal with some of these things.
And we need ophthalmologist also in the.
Oh yes, I'm sorry. Yes, you certainly need an ophthalmologist.
Yeah, Freeman, can you tell us something about your setup? Because Alfred DuPont is considered to be one of the best center for cerebral palsy management. So can you give us some idea about what is the best?
Yeah, so I think it is, I agree completely with the importance of having a clinic. And I think in this country, the sort of first multidisciplinary programs were established with myelomeningocele, where every child needs a urologist, a neurosurgeon, orthopedist, physiatry. And the problem that at least I sort of figured out, the problem with the diversity of cerebral palsy makes it very inefficient to have, say, 6 or 8 people standing in a clinic for patients that, you know, say a mild hemiplegic only needs to see the orthopedist if they're 8 years old. They don't need to see anybody else. So the way our clinic is set up is that we have a clinic coordinator and schedulers, and we have a pediatrician, physical therapist, occupational therapist, the whole team, but they're not all in the clinic at the same time. But we try to coordinate, depending on how far the parents travel, for them to get appointments back to back to each individual. And then we encourage having a weekly meeting to have communication about specific patients with the social worker about what the needs are. And I think this works in our system. I think the fact that you need a multidisciplinary approach is, to me, absolute and clear. The structure of that multidisciplinary approach, I think, needs to be regionally or in your locale, needs to be set up to what works for you. And number one, you need to have people who are interested, clinicians. The one thing that does not work is if some chief of a department assigns the youngest guy to say, okay, you're going to be the CP specialist, and the person has no interest in CP. It just doesn't work. You need somebody, you need people, whether it's ophthalmologists, gastroenterologists, pediatricians, that have an interest, that want to do it.
Okay, good. So multidisciplinary team is very important. How we structure it, how we create it, and how we function, that's again, it depends on the individual's practice, but it is very important. So then we come to the another important point of making a diagnosis. For that, any condition, whether it's a cardiology, whether it's medicine, whether it's ophthalmology, for making diagnosis, we rely on information, and we can get information from 3 things. The first is history. The second is the information which we get from the clinical examination. And sometimes we ask for investigation, and we try to have some spatial information. So all these 3 sources give us information, and from based on that, we either make a differential diagnosis, probable diagnosis, or exact diagnosis. Now, the question which I would like to ask is a practical question. So first of all, I will ask fellows' opinion, and then we will have experts' opinion. Here is a boy who is 4-year-old. There is a history of prematurity, admission in NICU for 7 days, family observed delayed development. On examination, there is a spasticity in lower limbs, and when child is walking, there is a seizures gait. So this is how the child is walking. So based on the history and clinical examination, the diagnosis of cerebral palsy is more or less certain. So now my question to you is like, will you go for any investigation in this child? When I say investigation, means I'm asking about specifically the MRI of the brain. So please let us know how many of you would consider for a diagnosis of MRI in this child.
Yes, we should do.
Okay, Yogesh says that we should go for the MRI. Okay.
Sir, is there any seizures or a history of, is there any history of seizures, sir, in this child?
No, there is no history of seizures.
Probably will not go for an MRI because it won't add to the management.
add much. It won't help us.
Okay. So if there is a seizures, will you go for MRI or will you go for EEG?
If the seizures are there, then probably EEG or MRI would be
No,
required.
EEG or MRI, like say, or both.
Both, probably both.
Okay, fine.
If I
Good.
did.
Yes. So anyone like Akash or Dr. Khatri, what do you think? What will you do? Okay, you have already written in the chat. So let me say,
MRI
EEG,
would
Akash,
delineate the reason how much has been involved.
okay, how that information is going to help us.
Is that progressive or not? The lesion is progressive or not?
Okay, so that means that every child in whom you are like suspecting cerebral palsy, you recommend to go for MRI. Is it correct?
No, not like that, sir. But MRI should be a part to make a diagnosis.
Yeah.
Okay, fine.
Sir,
We
MRI
refer to the pediatric medicine department, and probably they evaluate the patient and give the MRI to be done.
Okay, so let's have the opinion of expert on this, because like there is a two group. One says that there is no need of MRI. The other group says the need of MRI. So Benjamin, what do you think in India? You know the cost constraint, the financial challenge. So what will be?
Apart from the cost constraint, if a child comes to you at 4 years or 5 years with features of cerebral palsy, these changes have taken place because there's been some damage to the brain. The damage has occurred. It's irreversible. And unless you're dealing with a condition which is progressive or recurrent, you're not going to gain anything by having an additional MRI. Several of my patients come with an MRI taken somewhere and then say, here's the MRI, and hold it out as that's the most important diagnostic tool. And the truth is that virtually, I can say that the vast majority, it hasn't helped me. It might have explained that there is periventricular leukomalacia, agenesis of the corpus callosum, some old features of a hemorrhage or in a hemiplegic. Yes, that's true. It just confirms what has happened, but it doesn't help us in any way in the management. So it has not been my practice to have MRIs done unless there's a very specific indication, and that is usually when I refer to a neurologist with epilepsy or some other issue, and then we take an MR. So the answer is, as far as I'm concerned, there's very little role of an MRI to assist our diagnosis. But in specific instances where the neurologist feels that it might be needed, yes.
Okay, at this stage, I should acknowledge the message or the teaching which Benjamin has taught me when I visited Manipal for a short duration. He said that, Dhiren, before you prescribe any investigation, you should ask question to yourself, what information you are going to get from this investigation? Or the question you should ask is like, how this investigation is going to change my line of treatment. So I really appreciate, and I have asked this question many times, or almost every time I take my pen to write down or prescribe any investigation. And many times that question has stopped me to go for unnecessary investigation. So with that, Freeman, what do you think in your setup in a practice where the cost is not that big a issue? How do you go about in such cases?
I would agree pretty much 100% with what was stated. I would, the one thing, if this were the first time I saw this child, I would spend a fair bit of time going into the history of how the child was when they were 1 year old, 2 years old. Have they been getting a little better over the last 12 months or 24 months? Is the child, although they're scissoring, are they now doing better than they were, say, 1 year ago or 2 years ago? Any sign that the child is getting better is pretty much a sign that this is cerebral palsy. On the other hand, if the parents say, no, the child was walking around normally and only in the last year has this developed, then an MRI is definitely indicated. So it's I would not get an MRI. I would not recommend an MRI because the child will need an anesthesia or a heavy sedation to get the MRI. So there's also risk involved. And I completely agree it's not going to alter the care of what the child needs. If the child has seizures, he needs an EEG to see if the seizures are controlled with medication or what type of seizures can help with medication prescription. But I don't think an MRI will be of any benefit unless there's a sign that things are getting worse.
Okay, good. So I think there is no much confusion about that, and we go to the next point. So let's take the. Okay, so now coming to the important question, the role of MRI. Already we have discussed that the role of MRI is like when there is no history of predisposing factors. Yes, in that case, the history itself says that this cannot be or this may not be cerebral palsy. Or when the initial development is normal, what Freeman says that when the family says that the child was normal and this has happened only in last 2 or 3 years. So these are the two indications for getting an MRI done. Coming to the another question, which has been becoming very popular nowadays, what is the role of genetics in cerebral palsy management? I would ask straightway to Freeman because in India, genetics is very primitive at this stage. But what do you think in next 10 or 20 years, how genetics is going to interfere or like going to change our management? Yeah, Freeman, please.
Yeah, I think this is going to probably be one of the bigger advancements as the technique for being able to get sequencing gets cheaper and more accessible. Then I think it'll become much more a standard care. And I think there are two roles of genetic diagnosis. One is for parents who are contemplating having other children and want to know what is the risk that another child will have the same condition. Then I think it is genetic evaluation is crucial to be able to define that. And the second is there are some genetic diseases that are very treatable. And at least in this country now, there are newborn screens that have included some of these genetic diseases. And an example of one of these is in one of our local populations, there's a very high incidence because of consanguinity of glutaric aciduria, which is a condition in which the child is completely normal at birth. And only if they develop a high fever will they develop a severe brain injury. So identifying that at birth or close to near birth can prevent you from having cerebral palsy. It can prevent the child from getting the brain injury. So that's just one example of, and there are many other examples that both early diagnosis with genetics and the diagnosis to prevent other children makes this, and I think it'll become much cheaper. They develop these chips that if they're sort of known diseases in the community that you can screen, it's very cheap and quick.
Okay, so the three questions which we were looking for is like when you have already said that, why also you have explained, and which test. So just can you tell us which test would you recommend at this stage? Because there are various levels of test.
Yes, so the sort of most basic level is, for instance, one of the clinics that I attend has a metabolic, basically they do metabolic diseases, and they have now a chip that has 160 known genetic diseases in this community. So that they will bring in a child who has whatever abnormality and run that test, which is, they can do within an hour in the local lab. Then if you move to whole genome sequencing, which is, or disease specific panels, they get much more expensive and are harder to get and harder to interpret. And I think the whole genome sequencing, especially, to me, is still a little bit of a sort of black box. And I think you need to have specific reasons for doing that. It's very expensive and difficult to interpret. So if you know what you're looking for, then the test is much more fruitful.
Good. So now let's take another practical question, which time and again parents ask us. Like this family, the son is 6-year-old, was operated for the soft tissue surgery. And when everything was over, the parents asked me a question that we want to go for a second child. Which investigations we should undergo? This child had a classical history which suggests cerebral palsy. So it was not like that it was some genetic disorders or something like that. So in that case, should we go for a genetic, or should we advise the genetic testing, or we should say that take the routine precautions which Dr. Akash said in the initial part of the presentation? So first of all, I would like to ask the fellows, what do you think? How do you advise your family member, your patient's family about this? Yeah, Devendra, Siddharth, Akash.
We'll probably start the training program with the physiotherapy and.
No. I am talking of advices like they are going for a second child. So for second child, would you ask them to undergo any specific test? No.
No,
Okay.
you wouldn't.
No.
No. Yes. Akash, JP, Yogesh.
Usually do not advise any special test.
Okay. Any special test. Right.
It would be prudent to send them to medical geneticists, so that if at all some genetic cause is there, then it can be ruled out, sir. The specifics I'll not be able to tell, sir, but I think it's pediatrician's domain. But still, sir, they should be referred to pediatrician / medical geneticist.
Okay, so quick response from Benjamin and then Freeman about this. Benjamin, what do you think about this?
Realizing that the proportion of children who have cerebral palsy due to an underlying genetic disorder is a very small fraction of the whole population. And the risks are therefore relatively low. So I would counsel them and say the likelihood of another child developing cerebral palsy is very low. However, we can't rule it out in total. But that's true of anything. I mean, if it is not a genetic condition, if suppose it was prolonged labor, there's nothing saying that the next pregnancy also there will be no prolonged labor. So you can do nothing about it. So in general, I don't encourage further investigation. I do tell them, unless I have a suspicion that this might be of a genetic disorder, in which case, yes, I do that. But there's few and far between.
Okay, yeah, Freeman, what do you think about this? Or what is your take on this?
Yes, I basically tell them that the chances of their next child having cerebral palsy is twice as much as this one. So the first child of a couple has a risk of 2 in 1,000. And the risk for having a second child is, 2 in 500. And that is a very small risk, very low. And it's very unlikely that they would have another child. But if they are very concerned, I would say that they should visit a geneticist and, get testing and be given the complete odds that they can come up with. That's my approach to that question.
Okay, the one question or the one point which you said is like when first child has cerebral palsy, the second child has a higher incidence, possibility of higher incidence of cerebral palsy. So that was something new. So is it your, like say, experience, or it's a study which says that yes, it is definitely much more in the second child.
Yeah, no, I think the data suggests that I can't right now quote the article, but yes, it's my understanding that the epidemiologic data suggests, like for instance, if you have twins, you double the risk of having cerebral palsy. So if they get pregnant with a single, they would have the same risk of having cerebral palsy as if they had twins. It's you know, as again, a small risk, but there is an increased risk.
Okay, good. So that's another important point which we need to remember. Okay, now we come to another important point is a cerebral palsy mimicking conditions. So what we understand by CP mimicking condition is when we see the child in the clinic, most of the children, we are very clear that this is CP and this is not CP. But there is a small number of children who are between the two groups and where we are not sure whether it is CP or it's not CP. So this is what I call it CP mimicking conditions. They present to us with a CP and we really need to go for some further investigation. So in that case, how do you proceed? Freeman first and then Benjamin, like how do you do, what do you do in this case?
If the condition is, you know, again, I go a lot by the history. If I am thinking that the history is not typical of CP, then I think depending on the features, whether they're dysmorphic features or whether it seems like there have been setbacks or so, referral for either metabolic or genetic workup. And I think imaging, those three things are the next step to sort of sort out whether there's something else going on.
Okay. Yeah, Benjamin, how do you proceed in such case?
The thing is very much what Freeman said, but the only other thing I would like to mention is you come across a group of children who have developed features of cerebral palsy later on, like hereditary spastic paraplegia. An adolescent with that may manifest exactly like an adolescent with CP. And so some of your treatment will sometimes be quite similar. But if there's a history of progression, you know that it's not CP. And to my mind, that is the most important history taking that you should do. Carefully ask, is this any worse? How was it last year? Is it the same now? Now with the family often having video clips that they've taken on their smartphones, you can compare and see whether there's been a deterioration at all. So yeah, I don't think it is difficult in many instances to suspect that it is not CP, but we may not put our finger on and say this is such and such a condition.
Okay, good. So we are coming to the very relevant question to that. But before that, the CP mimicking conditions are why it is important to identify. There is a first question. When to suspect, already we have discussed. Which conditions can mimic cerebral palsy, that we will see in a minute. And the question which I want you to answer at this stage is like, should we start treatment on the ground that this could be cerebral palsy, or we should have an exact diagnosis, which is very difficult in many of these conditions. Particularly, we don't have a proper investigation facility in India. So Benjamin, what do you do? Will you start a treatment?
If there is a delay in milestones, if there are signs of features of CP-like feature setting, and I would start the treatment. But I would much prefer to have a diagnosis before I start treatment if I could. But if I can't, I would continue with the treatment and hopefully at some point along the way, we'd be able to establish the diagnosis.
Yes, Freeman, what do you do in your setup?
Yes, I agree. I think it's very important to start, you know, for instance, if you have a severe contracture, even if it's not CP, you might still need to treat that contracture. So I think you should do both the workup and the treatment at the same time.
Okay, good. So that's very important point that we don't wait for our exact diagnosis. before starting a treatment, we parallelly start the treatment. This is a very good article, and I will share with you. It's a metabolic and genetic disorders mimicking cerebral palsy. And they have given a red flags in the history when there is a no risk factor suggestive of cerebral palsy, or there is a positive family history of cerebral palsy. When we say a positive family history means when some other child has some neurological involvement, in that case, we think of that probably it's the same condition has been taking place in the second child. Fluctuation in motor symptoms, or symptoms are changing in relation with the time, or there is a progressive neurological symptoms. When these are there in the history, that raises a possibility that this could be not CP but something else, or regression of milestone. Similarly, there are few red flags. I'm skipping this because of the lack of time. I am going to share this article with you, which is a very good review article and will help you in your practice. So there are three conditions, or three group of conditions they have described. The conditions where there is prominent spasticity, or there are few conditions where there is a predominant dyskinesia, or there is a third group of conditions where there is a prominent ataxia. And based on that, we can suspect that these are possible diagnoses in this category. Okay, then I just would like to have a point, like many times we have a cerebral palsy as a first diagnosis. And over and above that, we have another condition which is taking place, or the child has that condition. And that really confuses what is actually happening to this child. One thing is, like, I have seen a CP with scurvy, I have seen CP with rickets, and there are few other conditions, like sometimes there is a CP with joint disorders. So Freeman, what do you think? How do you manage these children and how do you proceed for the treatment?
Yeah, I think this is one of the challenges over time, because there is such a strong supposition when you have a child, say, with a diplegia, obvious motor disability, or quadriplegic CP, that any pain or changes or so on tend to be ascribed to the cerebral palsy. And it's extremely important to always have an open mind about this and things like rheumatoid arthritis, which is not terribly rare in children, can occur. And I have a number of patients that I diagnosed rheumatoid arthritis in with cerebral palsy. Tumors, leukemia is another relatively common condition. And if you're seeing a high volume of children with cerebral palsy, I expect in the course of your career, you will see one or two who will develop leukemia, just because 1 in 1,000 children develop leukemia. And they are not immune to that, or other tumors. So always when things are not quite going right, think about whether there's something else in addition to the cerebral palsy. It's important, as we talked about with mimicking conditions, that you don't want to miss and say cerebral palsy is the wrong diagnosis. And, this happens sometimes, for instance, if a child has big calves and initially had a diagnosis of mild cerebral palsy when in fact they had muscular dystrophy. That's not what I'm talking about. Here, I'm talking about a child really does have cerebral palsy. He has all the prematurity, has every other thing, but then always be aware of other problems that can develop, because they're a normal child, and be aware that this is, I found, one of the fallacies that pediatricians fall into. They very quickly are ascribing, especially things like joint pains and sort of poorly described symptoms. Oh, well, it's part of their CP.
Yeah, Benjamin, have you seen such? I'm sure that you have seen a large number of cerebral palsy children. So you must have also come across.
One condition in particular is rickets. And there is a cause and effect relationship, because many of these children with cerebral palsy are not taken out and exposed to sunlight. And that occurs more in certain communities than in others. And so we've seen florid rickets and, with deterioration of gait pattern. And once the rickets is cured, they improve quite dramatically. So yes, that's something that we are very sensitive about. So metabolic bone disorders associated with cerebral palsy is certainly an important thing in my reckoning. But as Freeman said, any condition other orthopedic condition can occur, and we need to be careful about it.
Good. Okay, so now let's come to the patient which we saw last time, that 7 months old child who developed or he was diagnosed with periventricular leukemia and then cerebral palsy. So he started early intervention, physiotherapy, regular, everything. Now this child is 6-year-old and he's walking, but his walking is not normal. So the mother had a question that why my son Adyaman walks differently. So here is a walking pattern. So I would like you to comment on, like, say, how this video. Okay, then let's see this other child. So the question which I want you to think is like, why this children with cerebral palsy, they are walking like this? That is a question. So just go on telling the reasons why he's walking like this.
Spasticity of muscles, probably contracture also.
Okay, spasticity of muscles and contracture. Good. Then what
Hip
else?
joint abnormalities in the hip joint, the rotation abnormalities regarding
okay, rotational abnormality in the hip joint, right? Then
we finish all the issues related to the muscle first. Spasticity is one.
contracture is the other, which they said.
Can there be weakness?
Weakness.
Are some muscles weak in cerebral palsy?
Yes.
Yes. So when some muscle contracts in a normal person, the antagonist muscle reciprocally relaxes. In CP, sometimes that might not occur. Both muscles may contract simultaneously, and that's called
Co-contraction.
So the child may be walking abnormally because of muscle problems, weakness, spasticity, co-contraction. What about the absence of selective motor control?
He doesn't have dorsiflexion during
yeah, so there may be
planovalgus feet.
So any of these things related to the muscle can occur. So you should be able to list them. And as a consequence of that, you might have contractions. So contractions comes way down at the end. And then joint deformities. And then bony deformities. In this gentleman, can you see some bony deformities quite obviously?
bony extruing is
Yes. So what do you think there is in the tibia?
increased the tibial extorsion.
Yeah. So there could be a torsional abnormality. There could be a torsional abnormality. So, you must be analytical about it and think about it in those terms.
Why is walking with the crutches?
Maybe issues with balance.
Good.
Yeah.
Yes, very good. So basically, like when we see a child with cerebral palsy, we have to think of the following possibility. The reasons for abnormal walking could be either from the brain or the central nervous system, or it could be from the musculoskeletal system. So let us understand the first group, that is the reasons are arising from the brain. as already we saw that most of the patient have a tone abnormality, and hypertonia or spasticity is the most common tone abnormality. The second is like what we saw in this child, inadequate balance. And because of that, he was using crutches. The third is inadequate selective motor control, or the co-contraction is the third thing which is responsible for abnormal walking. The fourth one, which is we really don't measure it, and because of that it's very difficult for us to understand, is that there are few sensory issues which is not allowing them to walk normally. And the fifth one is already we discussed, and Dr. Benjamin said that the weakness. So these are the neurological factors. And then we come to musculoskeletal factors which are responsible for abnormal walking. And they are short muscles, or we call it contracted muscles or contracture. Then there is another condition or another problem, which is we have realized only in last 2 decades. And there is some muscles, they become long. We will see that in the next lecture. The third, already we saw that there could be a problem at the joints. The one which we saw in this case was the problem at the feet, the problem at the knee joint, and sometimes the child may have a problem at the joints, at the hip joint. And the fourth possibility is that it could be a bone abnormality, particularly in the form of torsional abnormality, or at the hip there is a excessive valgus or excessive anteversion. So basically, in nutshell, there are two major groups, the one which is arising from the brain and the second arising from the musculoskeletal system. So what I want now as a homework is basically for the sixth factor. The sixth factor is basically the one which we saw, the arising from the brain, that's a tone abnormality, the problem with the balance, the selective motor control, sensory abnormality, and the weakness. And the sixth one is the contracture. For each factor, I want you to prepare something about pathophysiology, means like why this problem takes place. When there is a brain injury, brain insult, the part of the brain is affected, and how, which part is affected, and that results into this problem. The second one is what are the ill effects of these problem in the walking. Like we saw that the child had a balance problem, and the ill effect we saw was like he was trying to compensate with the help of crutches. The third important point is how do we measure it? This is a bit important question, because it said that the things which we cannot measure, we cannot improve. So I always give an example of a diabetes. If we don't have a blood sugar monitoring, it's very difficult to treat diabetes. If we don't have a weighing scale, then it's very difficult to treat obesity. So the same concept, we should be able to measure the factor. The last is about can we cure it? This is another important point. The fifth point is like how to reduce its ill effect. Can we completely avoid it, or we can reduce it? So these are the points which we would like to discuss in the next session. So now I am stopping the screen sharing, and I want you to take the responsibility. Who is going to prepare for one factor and going to present in the next session? So this is now the homework for you, and this is the part of the active learning process. Come on. So like I told in the beginning that unless and until you carry out the weightlifting yourself, you are not going to get any benefit. So please tell me who is going to do the homework for which factor.
Sir, I'll do the tone abnormalities, neurological factors.
Okay, so Ankleshwar Bharti will be, you are from which institute?
CNBC Sachacha Nadu.
CNBC Delhi. Okay. So you will be taking about the tone abnormality. Okay. Then.
Yes, sir.
Good. Very good. Yogesh is, no, the pathophysiology, but which condition? So all the 5 topics you have to do for each factor. So Yogesh, which factor you would like to take? Devendra, Siddharth, Dr. Khatri.
I'll take up, sir, co-contraction.
That's basically the loss of selective motor control.
Yes, sir.
Okay, good. So we have first, third, then who else?
So I'll take balance.
Balance. So first, second, third are gone. Fourth, fifth, and the sixth remaining.
I'll do short muscles, short contraction.
Which one?
Muscle contraction, short muscle contraction.
Okay, muscle contraction. Okay, so that will be done by Siddharth, right?
Akash, sir,
Okay, Akash. Akash will be doing the 6th one. That's a contracture, muscle contraction. Okay, still 2 to go. The sensory motor problem and the weakness.
I'll do the weakness, sir. Dr. Siddharth here from my.
Yes, okay, weakness. The one which is very intriguing and where there is no much clarity is the sensory issue. Who would like to take that difficult challenge? Arul Burgun. Okay, if there is no taker for that, then I will present my views on the sensory problem. So with that, we end the today's sessions. Once again, thank you, Dr. Yes. Yeah, please, Freeman, please.
Can I make one comment? I'd like to add to your list. One thing is for people to ask if this is providing a benefit to the patient. We talked about the negative consequences, but so for instance, with muscle contracture, spasticity, and so on, also ask, is this providing a benefit to the patient?
Okay, so ill effects and the benefits, both.
Yes.
Okay, good,
both.
Good. Right. So fine. Thank you once again, Dr. Freeman and Dr. Benjamin, for your wonderful input. And I must admit that it's a learning for me also. So it's not only the teaching which we are doing, but we are also learning from them. And once again, thank you very much, fellows, for joining the session. I'm very happy that you are taking it very positively and actively participating in the session. Again, we will meet next Tuesday at same time. I know that for Freeman and Benjamin, I am asking too much for their time, but they are also kind enough to spare the time for the teaching. So that's really their kindness. And once again, my special thanks to you.
Yes, sir.
Yeah.
Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you so much, sir.
Yeah. Thank you. Bye.
Bye-bye.
Thank you, sir.
Bye. Bye.